Hi, my name is Andrew Edmonds, and I'm an epidemiologist at the University of North Carolina at Chapel Hill. I'm pleased to have the opportunity to preview our paper entitled Poverty, Deprivation, and Mortality Risk Among Women with HIV in the United States. There is accumulating evidence in the U.S. of a relationship between higher degrees of poverty or deprivation in a neighborhood and increased risk of adverse health outcomes for its residents, including death, but much less is known on this topic among persons, and particularly women with HIV. Therefore, we aim to estimate the effects of interventions to reduce neighborhood level poverty or deprivation on cumulative mortality incidence among women with HIV participating in the Women's Interagency HIV Study, the largest prospective longitudinal cohort of women with or at risk for HIV in the US. Starting in October 2013, we linked participants' geocoded residential census block groups to the 2015 Area Deprivation Index, or ADI, and to two different 2012 to 2016 American Community Survey poverty measures. This facilitated the categorization of locations where participants lived as in the tertile of U.S. block groups with highest poverty or deprivation, in the middle tertile, or in the lowest tertile. Then we used parametric G computation to estimate impacts on mortality over 4 years of improving each income or poverty measure by 1 and 2 tertiles maximum versus no improvement. 1,596 women were included in analyses. 74% were Black non-Hispanic. At baseline, their median age was 49 years, and they were most likely to live in block groups falling in the highest tertile of poverty or deprivation. During the study period, 6% were lost to follow-up and 5% died. Improving the tertile of individual income to poverty level ratio less than 1 by a maximum of 1 yielded a 4-year mortality risk difference of negative 2.2%. The estimate was negative 2.3% with a maximum 2 tertile improvement. Results were similar with the ADI and family income below poverty level measures, demonstrating consistency across distinct constructs of area level socioeconomic environment. One limitation of this study is that the analytic population may not have been exactly representative of women with HIV nationally, as these long-term cohort participants likely had better health and healthcare access than women in general. Still, our results are consequential because they support the notion that interventions to ameliorate neighborhood poverty or deprivation may meaningfully reduce mortality risk for U.S. women with HIV, and accordingly, they support policy actions to implement such interventions. On a population level, an intervention corresponding to the estimated negative 2.2% risk difference can be extrapolated as preventing roughly 30% of deaths among U.S. women with HIV. Thus, this work speaks strongly to the potential of socioeconomic interventions to improve the survival of this population. Thank you for your interest in this study.